very much. Note to self, need to revise my bio to AME to make it shorter. Yeah. So thank you very much. I will talk to you today about a new Center for Operational Research on Hepatitis B that is established through the Coalition for Global Hepatitis Elimination. The coalition has been around for about 6 years now. It was established in 2019 out of the need to strengthen capacity for accelerated hepatitis B elimination, with its programs being mainly under 3 pillars. One, to connect and support programs for viral hepatitis at the highest levels possible, including diplomacy and the creation of a UN group of friends. Second, to strengthen the evidence base that is required for hepatitis elimination, to identify where the gaps are and to see how we can close up these gaps. And finally, to mobilize commitment. And this ranges from funders to industry partners to ministries of health and at the more kind of like international organizations. And within the second pillar of strengthening the evidence base is where this new Center of Operational Research for Hepatitis B stands. This would be preaching to the choir about the burden of hepatitis B. We know that even though there is a WHO mandate to eliminate viral hepatitis as a public health threat by 2030, the significant burdens of morbidity and mortality are encountered with chronic hepatitis B and C. In Africa and in most parts of the low and middle income countries, we have an especially harder burden of hepatitis B. Estimates are that about 25% of the global burden of hepatitis B is in Africa, where we have about 65 million people living with chronic hepatitis B. Again, 25% of all deaths from hepatitis B happen in Africa, and new infections, 2 of 3 new infections are happening here, with very high hepatitis B prevalence amongst children under 5 years. It does not have to be that way. Hepatitis B is not an innocent infection. It is the leading cause of hepatocellular carcinoma, which is primary liver cancer, which is one of the leading causes of cancer mortality globally. In the case of hepatitis B, we have very sensitive diagnostic tools for which we now have point-of-care diagnostics that can be decentralized down to the primary care level. They are relatively inexpensive. But more importantly, we have effective treatment that has been shown to, although not eliminate the risk of liver cancer, but to significantly reduce it. And it is now available, should be available in most countries for very relatively cheap prices of about $30 per year. Despite having diagnostic tools and despite having effective, relatively cheap treatment, our coverage rate of hepatitis B screening and treatment remains very poor, especially in the Africa region, where less than 10% of those who are living with hepatitis B are diagnosed, and less than 1% are receiving antiviral therapy. Most of this poor coverage of screening and testing can be pinned down to the level of investment that hepatitis B has seen. I like this graph, which was kind of like looked at the level of R&D investment for different diseases, and you will see that hepatitis B received less investment compared to snake bite. I have nothing against snake bites. I'm very terrified of snakes, but I don't think the problems are kind of like comparable. So it just shows that hepatitis B is neglected, remains to be neglected, and as a result of that, we have very limited studies, very limited programs that have looked at how to implement hepatitis B testing, care, and treatment in low and middle income countries. I referenced to this earlier in the morning, a systematic review led by Alex, which looked at studies of hepatitis B, cascade of care, and we found that very few of these studies happened in Africa, and even fewer amongst those that happen in Africa happen at the primary care level. I think out of 110 studies that were reviewed over a period of 2013 to 2024, only 17% were done in the African continent. And in almost all, none of them did we have studies that looked at the entire continuum of care, especially amongst those done in the primary care settings. So what this means is that we there is a significant evidence gap in terms of how to decentralize hepatitis B care, how to look after patients who have hepatitis B in a more effective manner in low-income countries, especially in Africa. Around the same time as the systematic review was being done, which was in collaboration with the WHO for the development of the new guidelines, the Coalition for Global Hepatitis Elimination also engaged on an activity commissioned by Open Philanthropy, which is a funder who became aware of the burden of hepatitis B and wanted to understand how they can get involved. So Open Philanthropy commissioned a review to determine the evidence gaps of hepatitis B and where most impact can be done. Through this, the CGHE did a scoping review of hepatitis B, looking at the evidence, and what we found was there's extremely limited operational research being done in low and middle income countries. And if you exclude China, there were very few studies that actually looked at the implementation of interventions and what their potential impact can be towards hepatitis B elimination in low and middle income countries. Subsequent to this scoping review, the coalition gathered a group of experts, many of whom are in the room today, to look at the results of this scoping review, but also to have more in-depth discussions around what are the priority areas for hepatitis B elimination, what do we need in terms of evidence generation to be able to accelerate progress towards elimination. And from this scoping review and the workshop that was done in 2023, the coalitions developed an operational research roadmap to simplify hepatitis B care in low and middle income countries. This roadmap built on the evidence gaps that were also identified in the 2024 WHO guidelines, but it also aims to leverage the expanded and simplified hepatitis B management criteria that we now have thanks to the new 2024 hepatitis B guidelines. 4 key priority areas were identified in the research roadmap, all of which center around the main barriers and challenges to hepatitis B care. The first priority was to identify how to simplify delivery models of hepatitis B to ensure that hepatitis B care is decentralized, it is equitable, and it is available nearer to where patients live. The second priority was how do we improve interventions to eliminate mother-child transmission of hepatitis B, but not stop there, but use the mother as an index to offer hepatitis B services to their close contacts and other members of the family. The third priority was to develop and operationalize technologies for simplified hepatitis B diagnosis, treatment, and monitoring. And this revolves around leveraging new diagnostics, either those that have just become available or those that are currently in development, which would be relevant for decentralized hepatitis B care. And the fourth is to identify which individuals are at highest risk of progressing to fibrosis, cirrhosis, and liver cancer, so that these can be prioritized for closer follow-up, surveillance, and monitoring. Following the launch of this research roadmap, the coalition continued to engage with the funder, which is Open Philanthropy, and that has resulted in an initial investment from Open Philanthropy to establish a Center for Operational Research for Hepatitis B, with its main priority being to develop research projects that would close up these gaps and that are centered around the 4 priority themes that have been identified in the research roadmap. The center was launched at the Global Hepatitis Summit in March of this year, and we formally announced the launch through a correspondence in Lancet Gastro around the week of the Global Hepatitis, around World Hepatitis Day in July. We now have a website that I'm sure most of you have seen. So I serve as the Director of Research for the Center. We are supported by a scientific advisory group that comprise of global experts, clinicians, policymakers, public health experts at the highest levels with significant experience of implementing programs, conducting research, and working towards policy for hepatitis B in low and middle income countries. The main objectives of the center, at least in the first phase initially, are to build research projects that address the evidence gaps that have been identified in the research roadmap. And this would be to start to set up high priority research studies that would be that would generate the evidence we need to close the gaps and to demonstrate what are the best ways to decentralize hepatitis B care at the primary care level. Whilst doing this, to strengthen capacity and public sector engagement to make sure that services where hepatitis B needs to be available, the individuals there are well trained and able to do the bare minimum that is required, but also public sector engagement and from across all the partners, the manufacturers, the Ministry of Health programs, and other funders, while standing up these projects to embed in them cost effectiveness and modeling analysis to be able to identify amongst the different potential models of care which ones would be most effective, at which levels, the new diagnostics and tools that might be available, at what price point do they have to be available at different populations for these interventions to be cost effective and scalable for national programs. And then finally, to tie all of these up through the existing platforms that the coalition have, but with other partners as well, to disseminate findings as they are coming, and to try to use these to inform policy changes at the highest levels, nationally, regionally, and globally, to make sure that we are learning by doing and we are impacting policy and practice as we are going along. If we are able to do all of this, we expect that it could translate into increased funding for hepatitis B, into improved policies that are better suited for our settings and our patients, and for better health outcomes for everyone in low-income countries. This shows the timeline of activities for the first phase of the Center for Operational Research for Hepatitis B. In the first phase, phase 1A, which we are almost wrapping up now, this objective is to stand up the center, to develop the research questions and the protocols, establish funding mechanisms on how to collaborate with the research partners, and develop multi-year public sector engagements, engage with the partners who are developing programs. And then after that, to stand up these projects, make sure that the projects are rolled out over the next 2 to 3 years, launch cost effectiveness analysis models alongside these, and then initiate dissemination plans in terms of how do we engage with the policymakers, how do we make sure that the findings don't just stay at the publication journals, but reach the individuals who can actually impact change. And this just is a higher level summary of the key objectives for the first phase, which are to launch the projects initially, and then to make sure that we have a high impact research portfolio that will be impacting policy and change as we go along. Now, I'll use the last 7 minutes of my talk to just briefly give you an overview of some of the initial research projects that we will be starting off with in Core B for the first 3 years. The first project we would do, which is called the Thai B study, we'll do it in Thailand. It's a model of care that is looking at hepatitis B screening and treatment using a birth cohort approach. The Thailand Ministry of Health introduced hepatitis B and C screening of products very early in 1992 and rolled out hepatitis B vaccination amongst all newborns since 1992. What this means is that individuals who were born after 1992 have a much lower risk of hepatitis B infection compared to those who were born before 1992. Last year, the Ministry of Health rolled out a nationwide hepatitis B and C testing at the population level for all individuals born before 1992. But what we are finding is that uptake of screening remains poor. But even worse is the linkage to care of those who are found to test positive for hepatitis B has remained very low. So we are working with them to both evaluate the effectiveness of a nationwide strategy using a targeted approach of an at-risk population to identify and link to care those who have hepatitis B infection, but also to see how we can decentralize and simplify this care down to the primary care level so that it's not clustered and centralized at the tertiary levels. And we hope that the main outcomes of this would be both clinical at the patient level and programmatic at the Ministry of Health levels. And eventually, these strategies can hopefully be replicated in other countries in the region in Southeast Asia, but also in our context in Africa, where we might have some pockets of individuals who might be at higher risk compared to others in the population. The second study, which I am especially passionate about, is the one that I had alluded to this morning that we are doing with HepSanet. And this we are calling the Be Simple study. We want the name, as it says, it's to simplify as best as possible hepatitis B care in rural Africa. And we are developing a model of care based entirely on point-of-care diagnostics to be delivered by non-specialists. So this would differ from country to country, but in most cases, it would be a model of care delivered by nurses at the primary care level. The research question here is to determine the effectiveness of a simplified model of care that is integrated into primary care level, delivered by non-specialists using only point-of-care diagnostics, and we are looking at the accuracy of these novel point-of-care diagnostics and how they can simplify and improve the cascade of care for hepatitis B. We will work with HepSenet teams in Ethiopia, the Gambia, and Malawi. Okay, the screen has gone. And we're, again, similarly looking at clinical outcomes. We're looking at patient outcomes in terms of their preference, their satisfaction, and we're looking at the quality of care, comparing this point-of-care diagnostics model of care with the standard of care centralized at the specialist centers. We have a session tomorrow through the Research Partnerships Program where I'll go into more detail about what exactly we're doing for this and to demonstrate what point-of-care test we will be using. The third of the initial flagship projects that COHEP-B would be standing up will be an operational research project which aims to determine the best ways to integrate hepatitis and HIV care into an integrated model. For this, the center put out a request for interest that closed a couple of weeks ago and for which we've received 24 proposals. What we're looking for here is to evaluate integration models for simplified hepatitis B care integrated with HIV through either established sites or new sites that will be established. And we are looking at all sectors that would be important, from the design and implementation of the model to what potential impact it can have. And through all of these projects, we are working with Shevanthi and team at Imperial College London to determine the impact and cost effectiveness of the different strategies that we are developing, because it defeats the purpose if we find an amazing model of care that works, but that cannot be sustainable because it's not cost effective. And alongside these, because we are working with new partners who are developing new diagnostic models, we want to understand at what price point these new point-of-care diagnostics would need to be available at country levels for them to be cost effective. And lastly, in an affiliated study, which is not part of the central COHEP-B, but is funded by Open Philanthropy, and we're kind of like co-leading, is a vaccine trial that we're doing at the MRC unit, the Gambia, which is looking at using microarray patch, which essentially looks like a small piece of Band-Aid to scale up timely hepatitis B births, especially in out-of-facility deliveries. And this would be an early phase trial, which is initially going to look mainly at safety and immunogenicity of using this technology. We hope it will be followed shortly by larger trials that would show its potential impact to scale up timely births coverage. But just to give a brief idea about the MAP technology and the potential that it has, this, like I said, it's a simple plaster sort of thing that is usually coated by like whatever you want it to do, whether it's a drug molecule or, in our case, the hepatitis B vaccine that is attached on the skin of a newborn, and then the vaccine goes into the skin. Preliminary studies have shown that it could potentially elicit stronger immune response because you're delivering directly into the skin, which has more kind of like immune cells there. And so far, there's been an earlier study mainly using MAP for measles and rubella that was done in the Gambia that shows that it's safe, it's effective, and immunogenicity is good. But we need to demonstrate this for hepatitis B to be able to catalyze the evidence that is needed to push this further towards policy. My final minute, I will talk about new partnerships that we are developing at the center, which are mainly, for now, with industry partnerships, where we are trying to see beyond the products that are already available at the market, what are the tools that are in development currently that we can begin to engage with the developers, both to generate the evidence that this would work in low and middle income countries, but also once they become available, how can we use them? Can they be easily used in our settings? Would they be cost effective and all of those? And with that, I thank you, and we are continuing to look for partners and collaborators. So if you are aware of any partnerships that could strengthen the case for hepatitis B elimination in low and middle income countries, we would love to know about it. We would love to engage them as we stand up the center. Thank you very much.